So I've asked to be quick and brief. So my talk here will be about the immunoglobulin replacement therapy in inborn errors of immunity with focus on subcutaneous. So inborn errors of immunity is a heterogeneous group of disorders, as we all know, uh, characterized by an increased risk and susceptibility to recurrent severe infections as well as autoimmunity, malignancy, due to a defect of one or more components of the immune system. And they range from phagocytic disorders, cellular, humoral immunity, complement deficiencies, and so on. So more than 50% of these disorders are due to defect in antibody production, and replacement with immunoglobulin have been standard of treatment in those patients with hypo and agammaglobulinemia, as well as those with significant impairment of specific antibody formation. So this is a very quick immunoglobulin replacement therapy timeline, where it dates back in the late 1800s, where treating diseases with antibodies began after tetanus toxin was discovered. And in the 1950s, intramuscular immunoglobulins was used, proven to be effective during the measles epidemic. And subcutaneous immunoglobulin, the IVIG, the intravenous immunoglobulin, emerged as a new standard of care in the 1980s. At that time, the US and European researchers were conducting studies on subcutaneous immunoglobulins. And it wasn't till 2006 where the FDA approved subcutaneous immunoglobulin. And in 2016, the facilitated subcutaneous immunoglobulin, which is given every 3 to 4 weeks. So the methods of subcutaneous immunoglobulin is the conventional way as well as the facilitated way. And with the conventional way, it's usually a weekly administration using a small needle. It's a home administration using either manual or a digital pump. So in the manual form, as you can see in the upper slide in the right upper corner, usually it's given multiple times a week, so it can be daily, every other day, and depends on the dose. And it usually involves a small amount of volume, 2 grams only, which is around 10 to 12 and a half mLs of injection of immunoglobulin, which is given by hand and which usually takes no more than 5 to 10 minutes. The digital pump is faster, so it's given once a week, and it takes approximately half an hour to complete. And again, it's very convenient, requiring more sites. So the limitation is the volume that is infused. It's quite small. The need to inject on multiple sites, as well as the duration of the infusion. And examples of this is Hizentra 20%, Subgam 16, as well as Cuvitro 20%. Now the facilitated subcutaneous immunoglobulin. So it's facilitated, it combines between an intravenous approach as well as the subcutaneous approach, such as Hycuvia 10%. It has an enzyme, and this enzyme helps in during the injection create more space in the subcutaneous fatty tissue, allowing a more volume to be infused in one setting, and that's usually given every 3 to 4 weeks. The standard is 4 weeks, and it's generally better tolerated than IV infusion. So up to 600 mLs per hour can be infused, and up to 60 ml per site. And the indications is for primary immune deficiency syndromes, as well as with impaired antibody production, as well as specific antibody failure. And the question was how effective is it in preventing infections? In the pivotal study efficacy, where the primary efficacy endpoint was the rate of serious acute bacterial infections the rate per patient year, and the secondary endpoint rate of all infections per patient per year. So the In all, there were 87 patients that were studied, and less than one, so 0.025. Yeah, I see the pointer, but sorry. So 0.025, which is less than one serious acute serious bacterial infection was reported during the duration of study, and overall 2.97 infections per patient per year. And the two episodes were bacterial pneumonias that were treated with oral antibiotics in an outpatient setting, none of which required hospitalization, and the rate of all infections with IVIG was double that for the subcutaneous, 4.5. So most infections that occurred were sinusitis and some of bronchitis. Regarding the tolerability, the majority of patients, approximately 94%, achieved the same 3 or 4 week dosing interval during the IVIG treatment phase, and over 97% of these infusions were completed without having to reduce or interrupt or even discontinue the treatment. So the percentage of the infusions given at one site only was 72.5% if you had to take more than one site. And if we look at the pharmacokinetics, we had a really very nice distribution with subcutaneous immunoglobulin being more steady at around 10 grams per liter. You can see this very high, this very quick, I don't know how to do sorry, but you can see with the IVIG there is this rapid rise in the immunoglobulin levels, and less so with the facilitated immunoglobulins, usually by day 4, sorry. So when deciding whether to use to go for subcutaneous immunoglobulin or IVIG, it's like the slide that Marcus has presented. We have to take patient consideration as well, the treatment options available, as well as insurance coverages and so on. So subcutaneous immunoglobulin is an option. It's not to replace IVIG, so we should have both treatments available. The advantage is the ease of administration, no need for vascular access. The efficacy is comparable to IVIG, ability to infuse at home, and low rate of systemic adverse events. It has this nice steady state of immunoglobulin levels, so there is no wear-off effect. And it's well tolerated in IgA deficient patients, where the reason is the gradual exposure of IgA very slowly, which is absorbed from the subcutaneous compartment. Quality of life studies reported the preference of patients for subcutaneous over IVIG. The common side effects with intravenous route is really well known: headache, fever, fatigue, vomiting, requiring pre-medication. These are rarely seen with the subcutaneous. The serious systemic side effects usually it's only 1 to 3%, in the facilitated around 8%, but in IVIG it's up to 20 or 25%. Renal insufficiency, thrombotic events have not been noted much with subcutaneous immunoglobulin. So when the patient comes, or the relatives or the caregivers, we always give them all options which is available. In Oman, we have the intravenous IVIG and the subcutaneous. We do not have the facilitated subcutaneous yet due to cost issues, which is something to be borne in mind. But however, we do explain to the patients and caregivers the options available, the frequency of dosing. So every 3 to 4 weeks in the IVIG and facilitated immunoglobulin, but it's more frequent in the subcutaneous route. The IgG level, more or less no variation with the subcutaneous, but there is a very high peak, as I've shown before, with the IVIG, and less so with the facilitated immunoglobulin. The access is also an issue, so it would require an intravenous um, introduction in the IVIG. So usually it's a healthcare facility having to come to hospital, but not so much with the facilitated, and definitely very easy in the subcutaneous method. Needle sticks, so multiple sites might be a problem, especially in children. Um, the time of the infusion, which is much less in the subcutaneous um, intervention. However, in the facilitated and intravenous, it takes longer, so it does take roughly around 3 to 4 hours in order to complete the infusion. The ancillary people, so with the IVIG, it does require bed. For example, in Oman, we need the daycare bed as well as the nursing manpower and the time spent with registration, etc. But with the facilitated route and the conventional route, this all can be simple. But the facilitated subcutaneous immunoglobulin infusion does require a bit of help from the caregiver. It's not so easy practically to be administered. Intra-infusion systemic side effects we've mentioned. It is more with the IVIG, pre-medication with IVIG as well as the facilitated. Facilitated it might require pre-medication, but not with the subcutaneous immunoglobulins in the conventional method, because the dose is not biologically available for 24 or 36 hours. Intra-infusion local side effect. Now this is common with the subcutaneous and usually gets better slowly after multiple infusions, but we can try some tips like applying cold compressors, for example, or even in children probably applying some local anesthetic until they get used to it. Post-infusion side effects. The systemic side effects with IVIG is very well known. However, it is less with the facilitated, and in the subcutaneous, it's mainly, as I've mentioned, the redness and the swelling. Cost is really important, and this is why it was a little bit difficult to bring the subcutaneous immunoglobulin to Oman because of the cost. Now, this is where there was an analysis which we presented to our hospital, that the hospital visit cost as well as the physician cost, daycare, all ancillaries, nursing and so on, all of this really does cost, and not to mention the economic costs from missing days from school, at work. So this is really a problem, and the rules in the government sector in Oman unfortunately dictate that salaries are actually deducted if the parent misses work for more than 3 times. And this is a lifelong treatment, which is the reason why parents of those children come up and request whether these immunoglobulins can be given after hours. So which route is best? At the end, physician, patient, family, insurance, all these need to be taken into account. Thank you very much.